So let us look at diabetes mellitus this morning. But before we go any further into looking at the diabetes mellitus itself, let us quickly take a look at the anatomy of how insulin is important and where it is made from. So first of all, the important thing we should know is that insulin is produced in the pancreas. And this is an endocrine and an exocrine gland at the same time. In the pancreas, we have small gatherings of cells that are known as the islets of Langerhans, which contains alpha cells, B cells, gamma cells. And in diabetes mellitus, we are interested in the beta cells, which produce insulin. Okay, we're also interested in the gamma cell, in the alpha cells, which produce a hormone known as glucagon. So in the pancreas, we find that there are groups of cells that are known as islets of Langerhans, which contain different types of cells that produce different types of hormones. We have alpha cells, which produce glucagon. We have beta cells, which produce insulin. And in diabetes mellitus, these are the two cells that we're interested in. So the beta cells produce insulin. The function of insulin is that it is the one that allows for the uptake of whatever nutrients that have been taken up by someone in their meals. So once an individual eats their meals, the meals are digested and absorbed into the bloodstream, and then insulin is released. Once insulin is released, it allows for those nutrients to be taken up by the body cells in order to be used. This is known as the lock and key hypothesis. Without the insulin, these nutrients that have been eaten up will not be taken up by the cells. And so you find that when there is glucagon, on the other hand, glucagon, if someone has not eaten, the function of glucagon is to allow for the body to start digesting the stored energies, the stored glycogen, so that the person has a specified range of glucose in their bloodstream. So these two hormones work antagonistically. The insulin reduces blood glucose levels, whilst glucagon increases blood glucose levels when someone has not eaten. The other function of insulin is that it closes the cells, it closes the cells from breaking down whatever stored foods that are there, whatever stored fats, whatever stored food is there. If there is insulin in somebody's blood, it means the food that has been stored will not be allowed to be broken down. Therefore, glycogen in that case will not take its effect until the insulin levels in that human being go down. Now, let us start looking at diabetes mellitus itself. Now, diabetes mellitus is said to be a group of metabolic diseases in which blood glucose levels are abnormally high. This is due to defects in insulin secretion, insulin action, or both, and characterized by glycosuria, which is the presence of glucose in urine, polydipsia, which is excessive thirst, and polyphagia, which is excessive hunger. It is also characterized by an increased amount of glucose in the blood. This is known as hyperglycemia, and this is due to diminished effectiveness of insulin. There are several classifications of of diabetes mellitus, and there is, first of all, type 1, which is formerly known as insulin-dependent diabetes mellitus. This is because there is in insulin type 1, there is literally no insulin in this human body. The pancreas is not producing any insulin. Therefore, the individual is dependent on the artificial insulin that has to be injected in them. Okay, there is absolute deficiency of insulin due to autoimmune pancreatic B cell destruction. The B cells that are supposed to produce insulin in the pancreas are destroyed. Therefore, this human being has no insulin at all. Okay, onset is usually before the age of 30, but may occur at any age. And most of the sufferers of type 1 diabetes mellitus is they are usually very lean, very thin. We'll look at why in the pathophysiology. And these people are usually prone to ketosis. Ketosis is a situation where there is excessive breakdown of fat. And once there is excessive breakdown of fat, there is build up of ketone bodies, which are a product of fat breakdown. And once there is buildup of these once there's buildup of these ketones, this human being is likely to go into what is known as ketosis. Okay, it has a great genetic predisposition. There is a strong family association. And then we have diabetes mellitus type 2, where there is peripheral resistance to insulin action, okay? And then there is also impaired insulin secretion. So in type 2, first of all, there is resistance. The cells will not respond to insulin. Even if there is insulin in the bloodstream, the pancreas is functioning well, producing enough insulin, the cells will not respond to it. Now, this one is treated with diet and exercise, and then oral hypoglycemic agents, and it has a gradual onset. Sufferers are usually obese. Onset is usually after the age of 40, although it may occur at any age. So the differences between type 1 and type 2 diabetes, in type 1, you find that the typical age of onset would be below 40 years, and type 2 above 50 years. The body weight in type 1, you find that the patient may either have a normal weight, or they may be malnourished. They may be very lean, very thin. In type 2, most patients will be obese. In type 2, 1, you find that the patient is prone to the patient will have ketonuria. This is where the patient has ketones in their urine. Once you do a urinalysis, the ketones will be positive. Type 2 diabetes mellitus, the patient will not have ketonuria. In type 1, you find that there could be rapid death if there is no treatment with insulin, because the patient literally has no insulin at all. And in type 2, patient may survive without exogenous insulin. In type 1, you find that the patient has autoantibodies. These antibodies are the ones that are fighting against the pancreas. Okay, and in type 2, the patient has no autoantibodies, meaning the pancreas is okay, it hasn't been fought. And then in the diabetes complications, you find that in type 1, the patient may not develop complications, and then type 2, about 25% of the sufferers will develop complications. The family history in type 1 is common. In type 2, it can develop even because of somebody's diet, somebody's lifestyle as they grow up, which is maybe sedentary. Okay. And then in type 1 diabetes mellitus, you find that this patient may have other autoimmune diseases, whilst type 2, the patient may not have any other autoimmune diseases. And then the third type is gestational diabetes mellitus. This is a type of diabetes mellitus which occurs during pregnancy. Now, this is as a result of stress. The stress of pregnancy occurs in about 2 to 5% of all pregnancies. Okay, it occurs in about 2 to 5% of all pregnancies, may improve or completely disappear after delivery. Untreated gestational diabetes can damage the health of the fetus or the mother. So I find that the baby will be born very big, which this condition is known as macrosomia. The baby may be born with respiratory distress syndrome and also may be born with hyperbilirubinemia. Okay, so that is gestational diabetes mellitus. The fourth type is known as malnutrition-related diabetes mellitus. This is a type of diabetes mellitus associated with long-term malnutrition. Now, this one, you find that the sugar levels will just remain high in the bloodstream because there is derangement in the metabolism of this food. So this type requires the use of insulin for control of blood glucose levels. The patient will rarely go into ketosis. Okay. Now, what are the predisposing factors of diabetes mellitus? We are saying that the exact cause is unknown. However, we have predisposing factors, and these include genetic factors, meaning family history. All right. So if there is a family history, uh, you find that the patient is likely to develop diabetes mellitus, especially type 1. Metabolic factors, okay, for example, hormonal production may induce gluconeogenesis in case of emotional and physical stress. Decreased number of insulin receptors on the tissue, which increases the levels of the serum insulin, and therefore you find that the tissues will not be responding to the insulin. Microbiological factors such as viral infections like Coxsackie virus. So the infection with the Coxsackie virus may predispose somebody to having diabetes mellitus, and this one will result in the dysfunction of beta cells, and so the patient may end up developing type 1 diabetes mellitus, where the pancreas is unable to produce any insulin at all. Immunological factors, all right, immunological factors, where there's presence of autoimmune antibodies which destroy the normal tissues. And one of those tissues that will be affected will be the islets of Langerhans in the pancreas. And so the beta cells may be destroyed, and so the patient will not have the insulin produced by the beta cells. The pathophysiology of diabetes mellitus. So we're saying that in normal cases, the beta and alpha cells are the cells of the islets of Langerhans in the pancreas, where the alpha cells will produce glucagon, okay, and the beta cells will produce insulin. The glucagon or the work of glucagon is to increase blood glucose levels when it falls below normal. That is, when an individual has not eaten, glucagon will be the one to allow for the breakdown of the stored energies. The stored glycogen will be broken down so that glucose levels will increase in the bloodstream. On the other hand, we have insulin, which when someone has eaten, helps to uh, allow the cells to take up the nutrients that have been eaten by this person. Therefore, these two hormones are antagonistic to each other. So insulin allows the body cells to use glucose from carbohydrates and store the fats and proteins that have been eaten. So it acts like the key that opens the cell membrane to glucose, thereby promoting glucose uptake by the tissues. Insulin stimulates the liver to store glucose, and this glucose is stored in the form of glycogen, and then um, this process of storing glucose in form of glycogen is known as glycogenesis. All right. Now, insulin also inhibits tissue breakdown. Tissue breakdown, in this case, we are saying that has different names depending on what exactly is being broken down. So it inhibits glycogenolysis, so meaning it inhibits the breakdown of um it inhibits the breakdown of stored sugars. It inhibits ketogenesis, which is breakdown of fat, okay? And it inhibits gluconeogenesis, which is a conversion of protein to glucose, or rather glyconeogenesis, which is the formation of glucose from non-glucose sources. All right, so it inhibits ketogenesis, it inhibits gluconeogenesis, it inhibits glycogenolysis. Now, insulin and glucagon, these, because they work antagonistic to each other, they maintain the glucose levels of the blood. If someone hasn't eaten, glycogen comes into glucagon comes into play by breaking down glycogen. When someone has eaten, insulin comes into play by allowing the body cells, the body tissues to take up the eaten nutrients. So insulin therefore keeps glucose and blood within normal range. However, when there is not enough insulin or the tissues are not responding to the insulin, you find that the glucose levels in the blood will increase because this glucose is not being taken up by any cells. So it will just be there in the bloodstream. Okay? And this is known as hyperglycemia. Now, because there is increased blood glucose levels in the blood, this hyperglycemia, there is going to be shifting of fluids into the intravascular spaces. Now, if you remember the idea of diffusion, where we say, or osmosis, where we say osmosis is the movement of water molecules from their place of high concentration to the place where they're in low concentration, or movement of water molecules from a place of low concentration, meaning place where there is concentration of other molecules, into the place where there is concentration of uh other molecules are in high concentration in this other place where they're going, in order to dilute that place. So you're finding that when there is hyperglycemia, you will find that fluids will start shifting from the interstitial spaces, meaning from the spaces around the cells, from the spaces around the blood vessels into the blood vessels, in order for these fluids to go and try to dilute the blood, because the blood in this case is highly concentrated. Okay, now when there is shifting of these fluids from the extravascular spaces to the intravascular spaces, there is going to be fluid and electrolyte imbalance, because there is going to be too much water now in the bloodstream. Okay, there's going to be too much fluid in the bloodstream. Now, because of too much fluid in the bloodstream, the patient will then be going to urinate more frequently. And this is known as polyuria. Okay? So if the concentration of glucose in the blood exceeds the renal threshold, now because there is too much glucose in the bloodstream, the patient is going to, this blood, remember, is flowing all the way to the kidneys also. So you find that the renal threshold will be exceeded. Okay. Once the renal threshold is exceeded, remember in the kidneys, first of all, we have the production of the filtrate, from the glomerulus, and once this filtrate starts moving in the renal tubules, there is reabsorption of the things that are still needed in the bloodstream. Things that are reabsorbed in the bloodstream, some of them include sodium chloride, some of them include glucose. Now, when there is too much glucose and the kidneys are overwhelmed, you're going to find that some of the glucose will not be reabsorbed back into the blood at the level of the renal tubules. So this glucose will therefore be found in urine, which is not supposed to be, the case for a normal human being. Therefore, this patient is going to have sugar in their urine, and this is known as glycosuria. When the excess glucose is excreted in urine, it is accompanied by excessive loss of fluids, okay? Because there is so much glucose in the urine, you find that a lot of fluid will go with this sugar, all right? There will be excessive loss of fluids. There will be excessive loss of insulin. Now, because insulin normally inhibits glycogenolysis, which is the production of new glucose, okay? Which is the production of new glucose from stored energies, and gluconeogenesis, which is also production of new glucose, all right? When there is insulin deficiency, these processes will start occurring without restraint. So you find there is going to be breakdown of glycogen, all right? There is going to be breakdown of fats and proteins in order to form glucose. So these things will be happening without any restraint. And so there is going to be increased hyperglycemia. Now remember, even when the patient's cells are not taking up, the body cells, the tissue cells are not taking up this glucose, as long as there is no insulin, the body will break down whatever it is that has been stored. The interpretation, the brain will interpret the fact that the cells are not taking up the glucose that the person is eating, will be interpreted by the brain as if the patient is hungry, the patient has not eaten. Therefore, the interpretation will be that it should now make sure the body should now make sure it produces more sugars. Therefore, the cells will now release more sugars, because now glucagon will be released from the alpha cells of the pancreas, and it will go and allow for breakdown of glycogen stores, and it will allow for glycogenolysis, which is the breakdown of glycogen stores, and it will allow for gluconeogenesis, which is the breakdown of fat and protein molecules to form new sugars, new glucose to flow in the blood. Now, remember, the blood is already high in sugar, and so the breakdown of these will further contribute to increasing the sugar levels in the blood. And so you find that the hyperglycemia will now become even worse. Okay? Now, the glucosuria, okay, because of the glucosuria there will be because of the glucosuria in this patient, you find that as the patient is urinating, there is going to be glucose that will start settling on the glans penis of this, if it is a man, on the glans penis, and if it is in the woman, there will be sugar molecules settling on the vulva. Now, because of this sugar molecules settling on the vulva and on the glans penis, the patient will start experiencing itching in those areas. This itching is known as balanitis in men and pruritus valvae in women. The patients will start having the itching of the private parts. The breakdown of fat, okay? Now remember there is gluconeogenesis, which is the breakdown of fat and protein molecules in order to form new sugars. So now that breakdown of fat will lead to formation of what are known as ketone bodies, which are a product of fat breakdown. Okay, now when these ketone bodies accumulate in the body, the patient will go into ketosis, and this ketosis will further lead to metabolic acidosis. When there is metabolic acidosis, the patient may even go into coma. Okay, now this will further lead to stimulation of the control center. All right, the respiratory control center. And because the body is trying to get rid of the metabolic acidosis, you find that the body is going to want to have more oxygen. Because the body wants to have more oxygen, the respiratory center will increase the rate and depth of the patient's respirations. And so this patient will end up having Kushman's respirations. This is where the patient wants to draw in as much oxygen as possible and release as little carbon dioxide as possible. Okay, and release as much carbon dioxide as possible. Now, remember there is excessive fluids now, okay? Excessive fluids that are moving from the extravascular spaces to the intravascular spaces. This movement of fluid from the extravascular spaces to the intravascular spaces is leading the patient to having polyuria, okay? Now, because of the increased polyuria, that means that the patient, if now because of the increased urination, which is known as polyuria, it means that the intravascular spaces will continue drawing fluid from the interstitial spaces or from the cells around the vessels or in other tissues into the blood vessels. Because of this, the patient will now go into dehydration. Okay, the fluid is being lost, the patient is going to be dehydrated. And once the patient is dehydrated, the patient will want to take as much fluid as possible. Now, when the patient wants to take as much fluid as possible, this is known as polydipsia. Okay, this is known as polydipsia. Now, remember the cells are not taking up any food because there is no insulin. Because of no insulin, the patient's cells are constantly hungry. Because the patient's cells are constantly hungry, the patient is constantly hungry. And therefore, the patient is going to want to be eating more. And so, this is known as polyphagia, that is excessive hunger, excessive appetite. Okay, now in type 2, this is where we're going to have polyphagia. And so in type 2, impaired insulin secretion is not marked. Therefore, there is enough insulin present to prevent the breakdown of fat and the accompanied breakdown of ketone bodies is prevented. So you find that this patient in type 2 has enough insulin, and therefore, because insulin is there, there is no breakdown of fats. Because there isn't any breakdown of fat, there is no formation of ketone bodies. So you find that in type 2, the patient is not predisposed to diabetes ketoacidosis. Okay, the patient is not predisposed to diabetic ketoacidosis because in type 2 diabetes mellitus, there is enough there is enough insulin. However, in type 1 diabetes mellitus, there is no insulin at all. Therefore, there is increased breakdown of the stored fats, the stored proteins, and therefore this patient will be very thin, will be very lean, and they will be prone to ketosis, and they may go into diabetes ketoacidosis, which is a life-threatening condition where there is metabolic acidosis. And patient will go into a coma, and they should be treated as fast as possible before complications take the patient's life. The signs and symptoms of diabetes mellitus. We have classic signs and symptoms, and these include polyuria. This is due to osmotic diuresis. Patient is urinating a lot of the fluid that they have. Polyphagia, which is due to tissue, due to tissue breakdown. Polydipsia due to polyuria. Okay, patient will have glycosuria due to excessive glucose in the blood. Patient will have pruritus vulvar and balanitis, which is due to the settling of sugars on their private parts. The patient will have glycosuria due to excessive the patient will have dry skin and mucous membrane due to dehydration because the patient is urinating, okay, urinating too much fluids. Patient will have Kussmaul's respirations due to metabolic acidosis. The patient will be tired most of the time, and this will be due to electrolyte imbalance. The patient will lose weight due to depletion of water, glycogen, and triglyceride stores. The patient will be fatigued because there isn't enough nutrients in the cells. The patient will have visual blaring due to swelling of the lens of the eye. Patient will have ketonuria, especially type 1 diabetes mellitus, where there is fat breakdown, and so you find that patients will have ketones in their urine. And then how do you diagnose diabetes mellitus? So uh, history of the family will review that there is diabetes mellitus, especially for type 1 diabetes mellitus. You do a physical exam, and so you find that physical features will show. For example, if the patient is in hyperglycemia, patient's skin and mucous membrane will be dry. And you do a blood test, fasting blood sugar will be elevated above 6.1 millimoles per liter. Random blood sugar will be above 11.1 millimoles per liter. Urinalysis will show glycosuria. You do a postprandial glucose check just after they eat. You check what their glucose levels will be, and they may go as high as 120 milligrams per deciliter. Glucose tolerance test will be elevated. They will be unable to tolerate glucose. You can give the patient a sweet, and you'll find that immediately they eat it, the blood sugar levels will rise above the way they're supposed to rise in a normal person who has no diabetes mellitus. Now, how do you manage diabetes mellitus? There are several ways of managing diabetes mellitus according to what type the diabetes mellitus is. So in type, we're going to incorporate the following: the nutrition management for both types. You're going to incorporate exercises, especially in type 2. Blood glucose monitoring is very cardinal. You educate the patient on what foods they're supposed to take. You educate the patient on fluid replacement. Pharmacological therapy also is very important. So when you are talking about nutritional management, this is mainly for type 2. Okay, one of the main goals of diet therapy in diabetes is to prevent the sharp rising okay, of glucose levels. Therefore, you have to give foods that are of low glycemic index. So if you're going to give foods such as bread, cereal, rice, you have to make sure they are eating the food that is of low glycemic index. For example, brown bread, the bread that is made with whole grains, okay, cereal, rice should be brown rice, which is of low glycemic index. So you incorporate their meals with fruits, vegetables, okay. You follow the pyramid, okay, the food pyramid for diabetes mellitus, okay. And then you incorporate exercises to lower blood glucose by increasing the uptake of glucose by body muscles and by improving insulin utilization in type 2 diabetes mellitus. Insulin is there, remember. So we want this insulin to be taken up by the cells. For the cells to take up insulin, exercising is very important. And then you educate the patient, okay, on things such as diet, exercise, how much exercise should they do, self-monitoring. Advise the patient to buy themselves a glucometer, okay, so that they'll be monitoring their sugar levels initially every after they eat and see which foods cause an insulin, can cause a glucose spike, okay? And then also you educate them about modification of their lifestyle. Their foods should change. Their sedentary lifestyle should stop. Okay. Pharmacologic therapy include insulin therapy, which is used in order to control the glucose levels. Now, insulin replacement is the first management when it comes to type 1 diabetes, because in that patient, they don't have any insulin. So no matter what you do, their blood sugar levels will not drop. Okay? So when it comes to types of insulin, you have short-acting insulin. These are used for rapid reduction of glucose levels, and these will treat postprandial hyperglycemia, the hyperglycemia that happens immediately after eating, and they will also prevent nocturnal hypoglycemia. Examples include aspart, lispro, okay? Now, these can be administered alone or with long-acting long-acting insulin. Then we have intermediate acting, okay? These examples we have, the common one in Zambia is Lente, all right? And the long-acting insulin primarily used to control fasting glucose level, and an example is Ultralente. Now, this is an example of an insulin sliding scale. Sliding scales are not the same for every patient. It is the insulin sliding scale is supposed to be according to the levels, the blood sugar levels of a particular patient. Therefore, it is not supposed to be given to every patient. It's not the same one that is supposed to be given to every patient. So an insulin sliding scale is according um it is according to how the patient's sugar levels have been rising, how much sugar is there in a particular patient's bloodstream at a particular time. Okay, so for example, uh, if the patient has this column here is showing the blood glucose level. This column is here is showing us the type of insulin, the type of insulin, okay? So we have fast acting insulin, we have intermediate acting, okay? We have um So if the patient's level of glucose is at 4.1 to 8, this insulin sliding scale is saying we're not giving any insulin here. And always remember, when you're giving insulin, there are specific syringes to give insulin by. You don't give using those other syringes that are in meals. You use insulin syringes that are in international units. Okay, very, very important to remember. And so this column is showing us the level of this particular patient. So if you're saying that a patient whose blood sugar levels are, for example, between 12 to 14 millimoles per liter, then you're going to give these amounts of units. 2 units from fast acting, 4 units in intermediate acting, 6 units in long acting. So this is the way. It is an example of an insulin sliding scale that can be done for any patient. The patient can be prescribed an insulin sliding scale according to how their blood, how they are responding to the insulin. Okay. This is an example of this is how long these types of insulin can work in what amounts of hours. So for example, in rapid acting insulin, you find that the onset of